All right, so talking about the anatomic nervous system and sympathetic nervous system as well. So in our peripheral nervous system, it provides nearly every organ that has a double set of nerve fibers. And then our sympathetic is filled with the adrenergic fibers. That's on top of the kidneys. You have, it starts with that word, but I'm not sure what it's called. Adrenin, and something in the lymphatic. I can't remember. Fibers that exit the thoracic and lumbar regions of the spinal cord. And then in the parasympathetic, this is the relaxing side, you have the cholinergic fibers that exit the cranial and sacral portions of the spinal cord. So in the parasympathetic nervous system, it's also called the cholinergic system and the craniosacral system as well. Function is going to be maintaining a vegetative state, normal body activity, neurotransmitters, acetylcholine, and major nerves such as the vagus nerve, which is the 10th cranial nerve in the nervous system. There's the deactivating enzyme, which is your acetylcholinesterase. I forget what that does. That does a lot of different things. Acetylcholinesterase. It activates, it'll probably get into it here. So one way to remember this, right? You have your ACEs if you're in Vegas, ACEs in Vegas, vagus nerve, and ACE acetylcholinergic nerves. So it's going to block the effects of the parasympathetic nervous system, such as atropine. Atropine comes from the Atrobella nocturno something plant. And then in our sympathetic nervous system, also called the adrenergic system, is our thoracolumbar system. So lumbar being closer to the lower of your back, and then thoracic is closer to the middle of your center of gravity. Neurotransmitters, you have norepinephrine. Your deactivating enzyme is monoamine oxidase, MAO. You have your catecholmethyltransferase, your COMT. Never heard that until now. And then sympathetic is going to mimic the effects of the sympathetic nervous system with epinephrine. Looking at our sympathetic nervous system, so we have two types of receptors. We have our alpha adrenergic receptors, your alpha 1 and alpha 2, and then you have your beta adrenergic receptors, beta 1 and beta 2. As far as where the beta receptors connect to, you have beta 1 because you have one heart, and then beta 2 because you have two lungs. Alpha 1, one of them is for the heart, one of them is for your vasodilation. So it's going to stimulate and constrict your blood vessels in order for you to raise your blood pressure. So alpha 1 receptors, vasoconstriction. Okay, so it's alpha 1, not alpha 2. Maybe alpha 2 might do it too. Pupillary dilation, so your pupils are going to dilate, right, get bigger, and veins are going to constrict. Decreased renin secretion. See if we can keep this going with alpha 1. That's all it says about alpha 1. Nothing about alpha 2? All right, so beta 1, you have one heart. Stimulation causes, it's going to increase your heart rate. Chronotropy, think of chronos, time, right? The tick on a clock, chrono, it's going to increase that rate. Increased contraction is enotropy. I believe eno means something to do with a tree or root, something to do with the root. So I don't know, I think roots are like tough when you grab them, so it's going to make that strength to contract harder. Automaticity, I always get this one mixed up. Drumotropy, I guess think of a drum, right? It's automatic, like whenever you have a drum beat in a song, it's just something that's keeping the rest of the band in sync automatically. So think of it like that, drumotropy. So with beta 2, you have two lung stimulation causes. You have bronchodilation and vasodilation. And then in selective beta 2 agonists that we're going to use albuterol through nebulize. I believe that's the only way is through nebulization. Protocol would be 5 milligrams, so 2.5 milligram or 3 milliliter containers. We put 2 of those into a nebulized nebulizer in order to be breathed through a face mask. Non-selective beta 2 agonist. This is going to be dopamine. Dopamine is a good vasopressor. Selective beta blocking agents. We have non-selective beta blocking agents. Let's see what I missed down here. So we have non-selective being beta 1 and beta 2 blocking labetalol. That's good for increasing blood pressure. However, we never want to just increase the blood pressure by more than 10% if we're strictly doing it for the blood pressure. If they have a lower blood pressure, we want to figure out what the underlying cause is that's making that happen, treat that first, and then if it's still not going up, then we would provide labetalol. Also, we'd provide fluids, so fluid resuscitation. Nadolol, I guess it's another type of labetalol and propanolol. You can see that the names are the same, so if you see that on the test, just compare it to labetalol. Beta 1 and beta 2 blocking. And lytics block. So sympatholytic, it's going to block something. Mimetic means it's going to mimic something. All right, getting into trauma. So we have the kinematics of trauma. Think of motorcycle accidents. We have over the handlebars. What's going to happen? You're going to stop. It's that momentum's going to fly you off the bike because the bike weighs a lot more and it's stopping, and you're going to flip over it. So you're most likely going to get head and neck trauma. You're going to get compression injuries to the chest and to the abdomen. If feet remain on the footrest during impact, you're probably going to have a mid-shaft femur fracture. And that is going to hurt like nothing else because that is the strongest bone in your body. Perennial injuries as well. Think of angular impact. If the rider is often caught between the motorcycle and a second object, you also want to think in mind compression compartment syndrome. It might say that. So often vehicle, barrier, etc. Crush type injuries, open fractures to the femur, tibia, and fibula. Fracture dislocation of the malleus. Laying the motorcycle down and massive abrasions, road rash. You're going to slide on that thing. You dress for the slide, not for the ride. I wish I could say the same, but it's hot down here in Florida. I try to be as responsible as I can. So you want to treat this as you would a burn. Fractures to the affected side. Vehicle versus pedestrian. So tend to face the oncoming vehicle typically, and frontal impact above the knees and pelvis. Initial impact is going to be femur, pelvic injuries, internal hemorrhage. Think of where the bumper's typically at. That's going to take the first brunt. Secondary impact is going to be thrown backwards, head and neck flexing forward. I guess depending on, okay, yeah, you'd be facing the vehicle because you're looking at it like, oh no, a car. The third impact is thrown to the ground. This is going to be your tertiary trauma. So whatever happens with that too, you might smack your head, that'd suck. Vehicle versus pedestrian in adult patients. So everything I just said was for pediatrics, I just missed that. So now we're talking about adults. I guess they turn away from the vehicle. All right, yeah, I guess your natural tendency, never mind, is to run away from the vehicle. I don't think I've actually almost been hit by cars while running several times, but in my head, I always just imagine jumping and catching the windshield because I've seen it on Mythbusters. Now, if I mess myself up doing that, that's probably what would happen 90% of the time. But I have this like romanticized version of if I was going to be in a car crash, what I would do. Lateral posterior impacts, so you're going to be hit from the back or side. Initial impact, bumper striking the lower legs, you're going to get lower leg fractures, and then secondary impacts going to hit the hood and windshield. Femur, pelvis, thorax, spine fractures. Third impact, you're going to be thrown to the ground, hip and shoulder, hip and should injuries, I guess that should be shoulder, deceleration injuries, and fracture and hemorrhage. So as far as types of impact, we have down and under the pathway. I wonder if that can be, I don't know if you can see that or not, hopefully. Down and under the pathway travels downward into the vehicle's seat and forward into the dashboard or the steering column. Typically we're going to have issues with cardiac tamponade. If they smack the chest, that's going to be our number one worry or priority. Knees become a leading part of the body. Upper legs absorb most of the impact, and knee dislocation. You have the patellar fracture, femoral fracture, and fracture of the posterior dislocation of the hip, fracture of the acetabulum, vascular injuries, and hemorrhage. Chest wall is going to hit the steering wheel column or the dashboard. Head and torso absorb the energy. So yeah, cardiac tamponade, there you go. Contusion, pneumothorax, might have issues breathing as well. Up and over pathway, if the body strikes the steering wheel, the ribs and underlying structures are going to absorb that momentum. So you're going to have rib fractures, ruptured diaphragm, pneumothorax, pulmonary contusion, cardiac contusion, and tamponade, myocardial rupture, and aortic aneurysm. So if your head strikes the windshield, you're going to suspect cervical fracture and axial loading injury. So look for that spider web in the windshield. It's going to tell you if they smacked it or not. Car crash lateral impact. So this is really bad because you don't have as much steel or engine block or anything else between you and the car or object that caused that wreck. Now it's just you and the door, and there's not a lot of steel by that door unless it's a bulletproof vehicle. So a vehicle struck from the side, you have a T-bone collision, fracture of the clavicle, ribs, pelvis, pulmonary contusion, rupture of liver or spleen, depending on which side's involved, and the head or neck injury. If you have a car crash, the rotational impact and rollover crashes. So rotational, it is going to produce some injuries commonly found in head-on and lateral crashes. So you could have ejection as well, just due to that centripetal force. You might fly out of either the windshield or the side window, most likely, because the windshield's most likely not going to break. Rear end impacts, you're gonna have to deal with whiplash, vehicle struck from behind, back and neck injuries, hyperextension, blast injuries, explosion, bombs. Primarily blast is the pressure wave, the primary blast. And then you have the secondary and tertiary blast. So I talked about this before. Basically, imagine a nuke going off, right? That initial blast that happens, that just wipes everything out. That's your first wave. And then what comes after that? You're going to have flying debris of cars, buildings, I don't know, cats, things that are going to fly from the device itself. Metal, if it was a grenade, the metal shrapnel would hit you. That's your secondary blast. Tertiary blast is the patient that is thrown and injured by impact on the ground or other objects. So by the time that you get lifted in the air, if you haven't been vaporized or smashed by something else flying in the air, you yourself are flying into a building, that's going to be your third blast. And then there's actually a quaternary blast. It's not the radiation, however, that is a side effect, but like once a bomb goes off, what happens is there's a vacuum that takes place, right? It just blew all of the air that is in that area of the earth away. There's nothing in there for however amount of time it is. And then once all of that pressure alleviates, that air is going to come pouring back in as if, I'm trying to think of an example like with water. Like if you took an upside down cup and stuck it under water and then flipped it up, that big air bubble comes out, right? Well, then the water sucks in and rushes. Now that's what's happening to the air. Air is a fluid, and that fluid is going to come right back to the epicenter of that blast and pulling you and everything else with it backwards towards where the blast just came from. Kinetic energy is 0.5 mass times velocity squared. Back to physics. Oh yeah, this one. So with burns, we have the rule of nines. Always think of your hand on your body right here, 1%. So if I did this 9 times, it would take up my whole arm. Rule of nines, my left arm completely is 9%. With my legs, if I did it 9 times, it would be the anterior side of my leg. If I did it 9 times on the back, it would be the posterior side. So legs, each leg is 18. 18, 18, 9, 9. So 36, 45, 6, 54. And then we have our torso. So 9 on the front, 9 on the back. And then head, which is, I feel like it's not, I guess your head's, depending on how big your head is, it's rule of 9, so just round up. And then your junk, that's going to be 1. No matter who you are, it's 1%. Oh wait, head is 4.5. Well, total head. So posterior, anterior, 4.5, 4.5. Head is 9 total. Oh, and the, okay, so I got this wrong on the torso. 9, whatever's on the superior, inferior. So 9, 9, 18. Back, 9, 9, 18. Infants, you have 18 on the head, 9, 9, 14, 14, 18 front, 18 back. So I guess just no 14 for the legs. That's like the main curveball with infants. All right, so with burns, we have toxic inhalation, inhalation injury. You have synthetic resin combustion, cyanide and hydrogen sulfide, systemic poisoning, more frequent than thermal inhalation burn. So signs and symptoms of inhalation in the injury above the glottis. This is dangerous because once you add heat, it's going to inflame. It's not as bad as if your hands or your legs or anything else gets burned and gets inflamed and swells up. But once your throat gets inflamed, you have an inner circumference that is closing at that point, and that is very dangerous. I think I skipped ahead. So the upper airway normalizes the temperature of the inspired air, which is great because it protects our lower airway from these extreme temperatures. However, it sustains the impacts of superheated air, right? So that superheated energy has to go somewhere, and it's being taken into your throat. So facial burns that have singed nasal or facial hair, sooty sputum, hypoxemia, stridor, red mucous membrane, and grunting respiration, they might not have had all the symptoms happen yet. That's going to come with that superheated gas inhalation, but their body is currently working to close it for the sake of protecting itself. So you have very little time to go ahead and put an airway into that person. Signs and symptoms of inhalation injury below the glottis. So steam inhalations are more likely to reach the lower airways. Has a 4,000 times the heat carrying capacity than dry air. Steam is bad. Wheezes, crackles, and rhonchi. Productive cough, hypoxemia, and bronchial spasm. So understand the difference between upper and lower airway burns. So crackles, rhonchi, just that in and of itself, bronchial spasms, all of that is happening in the lower airway because that's where your bronchioli, and bronchus, bronchioles, all of that is going to make crackles and rhonchi sounds. And then upper airway is going to be stridor, wheezes, yeah, those are going to be the sound, and grunting. So carbon monoxide poisoning. Affinity for hemoglobin, 250 times more than oxygen. It's going to create a carboxyhemoglobin. It's an odorless, tasteless gas. You will not know or be aware of it being there until you have a headache and feel lightheaded and woozy because you're not perfusing air. Cherry red skin is only present at levels when you have less or more than 40%. Multiple feelings of ill in the same resident building. So a sign of this is if more than one person is feeling some type of way, then that's a sign that something environmental is going on and not necessarily that patient's own personal symptoms. People feeling ill in the same, CO, carbon monoxide, produces false pulse oximetry reading, right? So if you have oxygen, the person's 100% oxygenated, and you put that on, it's reading that O molecule, that oxygen molecule. Well, just like O2 has a carbon, has oxygen on it, carbon monoxide also has an oxygen molecule on it. And now that I'm thinking about this, carbon dioxide also has an oxygen molecule on it. So how come it doesn't pick that up, but it picks up carbon monoxide and oxygen in general? But I don't know. That's for another time. Acid and alkali burns. So acids are worse. No, alkalis are worse. Acid, burning process that lasts 1 to 2 minutes, and it's going to cause coagulation. You're going to get a massive scab. However, alkalis, the burning process could last for minutes to hours. It's going to cause a liquefaction necrosis. It's going to seep deep into the dermis and keep causing reactions as it goes down, as opposed to acid that kind of just sizzles on the top. With fort fractures. So I guess a way to remember this, let's see, if you separate your nose from as if you had a mustache, that's 1. If you go up a little bit higher, split the difference between 3 and 1, that's going to be 2. And then whenever pretty much your eye sockets are split to here, it's going to be 4 or 3. Yeah, almost to the top of your eye sockets. Types of amnesia. So we have retrograde amnesia, if there's no recall of events before the injury. And then we have antegrade amnesia, so an inability to create new memories that exist after recovery of consciousness. There's been a couple of times that I've had retrograde amnesia from patients. I know there's one kid, it's funny, he was actually like in the fire academy, like just got into the fire academy, and I guess he was like causing shenanigans with his friends, like riding around in loots in the back of a truck, pickup truck, and he fell out, hit his head, and dude was just like, he had like some blood coming out of his ears and everything else. He was conscious, but he kept asking us he kept saying the same things over and over again, like, don't tell my dad. I need you not to tell my dad. What happened? I don't want to go with you guys. Don't tell my dad. Don't tell me what happened. And it's like, bro, I'm like, I told you, oh, he has amnesia, you know? And so he was a trauma alert that we transported. Antegrade amnesia, inability to create new memories, exists after recovery of consciousness. Okay, so this is, I don't know how long that lasts for. That's more of a chronic thing that happens once you've recovered. So you have types of head bleeds. We have subdural, we have subarachnoid, and epidural. Think of the subarachnoid is the webbing kind of in the middle between your subdural and epidural. Epi means on the outside of the skull. I believe that's where the dura mater is, which means tough mother. Subdural is deep, pretty much where the brain is. So it's a collection of blood between the dura and the arachnoid mater. You have a venous bleed, more common than an epidural bleed, so there's a slow onset of symptoms. You're going to have nausea, headache, decreasing level of consciousness, coma, and posturing. We have decorticate and cerebrate, decerebrate or cerebrate posturing. So cerebrate is worse. It's where the person is almost like their wrists are flexed like this, and they're like a dead body that's just like almost like it's been there for a minute. So that's going to be posturing, decerebrate. And then decorticate is where it's reaching towards the corticate. Cerebral cord? Yeah, cerebral cord. So they're like reaching up towards their head, almost like a vampire. And that's going to be less potent than decorticate. So this happens, and then after enough time, this will happen. Subarachnoid. Where was I at? Oh, yeah. Intracranial bleeding. So in the cranial, bleeding into the central CSF, central spinal fluid, cerebral spinal fluid. Sudden and severe headache. You're going to have a slow onset of symptoms. So worst headache of my life, super painful, migraine, dizziness, neck stiffness, unequal pupils, vomiting, seizures, and decreased level of consciousness. So if you have an increased intracranial pressure, you're going to have Cushing's triad. Make sure you know Cushing's triad. Let's see, what is it? Your heart rate's going to slow. Your blood pressure is going to increase and also going to widen. Heart rate slows. I want to say pupils are blown or dilate. Let's see. So normal ICP range is 10 to 15 millimeters HD or less. Treatment, we're going to give O2. Capnography monitoring of 35 to 40 millimeters. Here we go. Bradycardia, slow heart rate, irregular. Okay, so systolic pressure is going to go up, but not necessarily diastolic pressure, so it's going to widen and also be increased. Forget what I said about the pupils, but you're going to have irregular respirations, probably going to be Biot or Cheyenne-Stokes breathing, unless that's DKA. Which one's Cheyenne-Stokes? Biot? Which one's DKA? Cushing's? Kussmaul. Kussmaul is DKA. Biot and... What, I just said it. Cheyenne-Stokes is for brain injuries. And Cheyenne-Stokes is going to be rhythmic and regular. However, Biot's going to be irregular all over the place. So irregular respirations, it's probably going to be Biot's. Unless there's one that I don't know about. Spinal cord, we have axial loading. So this is going to be vertical compression of the spine that results whenever there's direct forces that are sent down from the spinal column. You're going to have compression fractures or crushed vertebral bodies, T12, thoracic 12 through lumbar 2, and then a central cord syndrome. Hyperextension is cervical injuries, a greater impairment of the upper extremities than those of the lower extremities. Paralysis of the arms, sacral sparring, and prevention of sensory or voluntary motor function of the perineum, buttocks, scrotum, or anus. Anterior cord syndrome. So this is usually seen in flexion injuries, a decreased sensation of pain and temperature below a level of lesion. So intact, light touch, and position of sensation paralysis below the level of lesion. Then you have Brown-Séquard syndrome. So a hemotransection of the spinal cord. There's going to be weakness of paralysis of the extremities on the same side, ipsilateral, and then of the injury with a loss of pain, the temperature sensation on the opposite side, so contralateral. So ipsilateral if it's on the same side, and then contralateral if it's on the other. Hemitransection, simply put, means half the cord has been transected, and an easy way to remember this is between the Brown and Séquard, think of the hyphen as being a half transection, right? So now everything down here is compromised. Hemothorax, tension pneumothorax. Hemothorax means there is going to be blood, blood, thorax, thoracic cavity, lungs, and then tension pneumothorax, there's going to be tension, air, thorax, again, thoracic cavity. So we have tachypnea, dyspnea, issues, irregular breathing, fast heart rate, cyanosis, they're going to be mottled in gray and blue. Diminished or decreased breath sounds, tracheal deviation, so that's going to be more of a late sign, and then asymmetrical chest rise. So if one side is struggling, one side's too tight, blown up, it is pushing your trachea one way or the other. Hemothorax. Your accumulation of blood in the pleural space may be a massive 2 to 3 liters of blood. That's like half. Yeah. Dullness on percussion, so you're going to have hyporesonance. There's going to be no resonance because it's like flicking a water balloon, right? It's going to be like nothing. It's just absorbing it. As opposed to air, imagine like a drum that's like tight, and then you hit the drum, and that's why drums make loud noises, because they hyperresonate. Hyperresonates. You're going to have narrow pulse pressure, hypotension, and hypovolemia. So there's going to be less blood in the system, which is why blood pressure is going to be low, because it's all in the lungs, the pleural space. Needle decompression, let's go to tension pneuma. So accumulation of air in the pleural space, said that. Hyperresonance, said that. Subcutaneous emphysema, it's going to feel like bubble wrap whenever you press, and it'll feel like Rice Krispies. Patient will become hypotensive in late stages due to obstructive shock, because it is so much pressure. It's pushing against where the, I don't know if it's the heart or the vena cava or whatever. It's pushing on it, so you're going to have obstructive shock. It's obstructing it. Needle decompression. So you're going to use a 10 or 16 gauge IV needle, at least 3 1/4 in length. Insert the needle above the rib to avoid the nerves and the vasculature that run under the rib. Historically, the second intercostal space, midclavicular. So where's our clavicle? It's right here. What is the middle midclavicular of the clavicle? It's going to be here, and then you want to count. That's 1, 2. So you're going to find that intercostal space, go down, and you want to press the needle right where the third rib is touching the second intercostal space. So you want the intercostal space, but right above the third rib. Midclavicular, updated evidence. Okay, yeah, I was about to say, because that's not what we learned. So yeah, updated is fifth intercostal space, anterior axillary. So anterior axillary, if we go to, one easy way to do it is you take your hand, put it under your armpit, and then right where your pinky pretty much is, that's going to be your fifth intercostal space. So come over here, and right where you feel is your anterior front axillary. Yeah, anterior axillary. So you're going to take that needle, press it in just above the 6th rib cage. Now, if you're going to hear whistling, and then if it stops and you're still having issues, get a second needle right next to that needle. Stick it in.